Mr. Chairman, ladies and gentlemen, I would like to share with you in the next few minutes our experience in this relatively new interventional procedure represented by percutaneous pulmonary valve replacement as an alternative or in combination with the surgical pulmonary valve replacement that Dr. Frigiola has already talked about you. This procedure actually started many years ago. The first in-man case was reported by Philip Bonhoeffer in 2000, so 13 years ago. However, it is relatively recent spread of this procedure all around the world. I mean, probably the last 5 years represent a worldwide experience in this procedure. The target population is represented by a variety of patients with conotruncal malformations, basically tetralogy or pulmonatresia VSD or complex transposition, or truncus or others that underwent repair, surgical repair, with the placement of right ventricular to pulmonary artery conduit. And as you know, the surgical conduits, particularly if they are placed in the small children, the lifelong is not for many years. It varies from a few years to the maximum to 20 years maybe, but much less than that in the majority of cases. So we have to do something for these conduits. And in many patients, a redo operation had to be performed 3 times, 4 times, even 5 times. And the surgeons would agree that all redo cases, all redo operations are at higher risk and more difficult. So if there is a way to avoid redo surgery or delay the need of redo surgery, is certainly very welcome. Well, the most commonly used device is the Melody, which is a piece of bovine jugular vein which is sutured on a CP stent, and this valve stent can be crimped down on a balloon and re-expanded up to the size of 18, 20, or 22 millimeters with a delivery system. That's a balloon expanded type of stented valve. Of course, the main indication is to reduce or abolish the possible stenosis of the conduits without inducing pulmonary regurgitation. The preoperative assessment, basically obtained by MRI, is of crucial importance. Of course, we have a large variety of right ventricular outflow tract morphologies, and not all are suitable for stent implantation. We have to have a conduit where we can place a stent which remains stable and will allow later on to put a valve in. So the MRI is the key imaging tool for assessing the anatomy and the physiology of the right ventricle. This is an example of a stenotic and mildly regurgical conduit with a corresponding 3D reconstruction, which is very useful to get an idea about the morphology of the outflow tract. And it is also important in the cath lab to obtain pictures that are matching the pre-procedural assessment by non-invasive tools. And you can appreciate in this angiogram the stenosis of the conduit, but also the calcification around the conduit. The CT is also useful in some cases, particularly where for some reasons MRI is not feasible or contraindicated, for example, in some selected cases with pacemaker implantation or other reasons. Well, the routine procedure included selective coronary or aortic root angiogram by balloon inflation in the RV outflow tract when we want to place the device, because we have to rule out the possibility of coronary compression, which is a potentially a very serious complication in this setting. In the vast majority, we went ahead and put a stent or 2 stents or more stents. So the pre-stenting is a routine in the vast majority of cases. And then we implant the Melody stent. This is a Melody device with the balloon inflation and expansion of the stented valve. And if you have some residual gradient or residual waste on the stent, is it quite possible to post-dilate the stent with high-pressure balloon to get rid of the residual stenosis, and because this is also important for the long-term survival. And as you see, there is no gradient, no stenosis, and no pulmonary regurgitation immediately afterwards. It's very important to assess the anatomy in order to plan the proper procedure. This is an example of a distal conduit stenosis, and that's the angiogram immediately after Melody implantation. That's another example of a severe, very long segment stenosis where multiple stents implantation was necessary to build a good landing zone for implanting the Melody, with eventually we got result. That's another example with a massively calcified homograph with almost no stenosis but massive regurgitation, as you see in both MRI and angiogram. Incidentally, in this particular case, there was also a stenosis of the left PA. So a stent was placed first in the left pulmonary branch, then the Melody implanted, and that's the final result with no obstruction and no regurgitation. This is another example of other type of conduit that can be placed by surgeon between the right ventricle and the PA. That's the Enco conduit. In this particular case, a metal rigid ring on the conduit is not necessary in the vast majority of cases to put a stent before. So pre-stent is necessary with an Enco conduit. Or another example, that's a dysfunctioning bioprosthetic valve, biological valve in pulmonary position with a double outlet in this case. You see the native outflow tract and the regurgitant prosthetic valve, and this is a Melody valve-in-valve placement. This setup, as mentioned by Sandro Frigiola, is probably the ideal and the easiest way to put a percutaneous valve, because we have a metal or rigid cage of the bioprosthesis that the surgeon put it before, and that's the ideal reference point and landing zone for putting a percutaneous valve. So surgeons are encouraged to choose a type of surgery that is going to be useful for possible non-surgical intervention in the future. Well, the worldwide experience is wide now with a high success rate and reasonably low complication rate. Of course, the complications are there. They're not zero. I would say the most important complications are the possible rupture of the conduit or coronary compression. That's an example of a heavily calcified conduit, as you see here, approached by jugular vein approach because of bilateral vein occlusion. This is a stent, the Melody implanted, as you see, with excellent result. However, if you look at these two pictures carefully, you may notice a difference here. If you don't notice that, I can help you in putting an arrow where the calcium has broken. Luckily enough, in this particular case, with no consequences, but you have to take into account that you may have major rupture of the conduit with possible severe bleeding. So that's a possible severe complication, particularly in calcified conduits. So how to prevent this possible complication? My answer is the following: pre-stenting with cover stents, at least in high-risk patients, particularly the patient with tight stenosis and massive calcification. This is a typical example of a complex transposition after Rastelli. You see the tight stenosis, massive calcification of the conduit, and the surgical patch put to close the VSD. A pre-stent was obtained with the CP cover stent, which is expanded here. You see the stenosis is so tight that it was impossible to achieve a full expansion of the stent. However, unless you may already use high-pressure balloon, if you have incomplete stent expansion, we can go ahead and post-dilate with high-pressure balloon, because the cover stent is to some extent protective against rupture and bleeding. So that's the final result after Melody implantation, with a reasonably good result with a mild residual stenosis and no regurgitation in the very complex and severe lesions. Well, the issue of coronary compression is very, very important. This is an example of an original case reported by Philip Bonhoeffer. You see, that's a pioneer experience. After Melody implantation, the patient arrested. You may see that the left coronary is not present anymore because of coronary compression due to the stent. Luckily enough, in this case, the chest compression was enough to squeeze the stent and to restore the flow in the coronary, so the patient survived in spite of severe problems. So we have to avoid this problem. So how to do? I show you an example. You have to rule out the possibility of coronary compression. This is an example of a complex pulmonary atresia with severe conduit stenosis, as you see here. Well, seems to be an ideal candidate for putting a stent and a percutaneous valve. However, as I mentioned, we have to be sure that we are not going to compress the coronary. So routinely, the test is implemented in the procedure: aortogram and simultaneous balloon inflation in the RV outflow tract to rule out coronary compression. And as you see here, the balloon is inflated and the left coronary is gone. And the flow in the left coronary is reappearing and restored when deflating the balloon. So obviously, this is a patient that should be excluded for this percutaneous procedure. But if you didn't do this balloon test in the RV outflow tract, putting a stent there would have resulted in a catastrophe, of course. Well, there are limitations for Melody, represented by RV outflow tract reconstruction without a conduit. At least that's a topic that I will mention to you later on in a minute. RV outflow tract larger than 22, because the maximum size of the Melody is going to be 22 millimeters, or generally speaking, an unfavorable anatomy for securing stent anchorage. So are there any alternatives? The answer is yes, to some extent. That's the Sapien hydrous pulmonary valve, which is available in two sizes, 23 and 26 millimeter, and therefore they can be used in larger conduits where the Melody is not. This is an example of a calcified homograph where probably both Melody and Sapien could be used, while routinely a pre-stenting is performed. This is an implantation of a bare metal stent, that is the under stent, with a semi-open cell design, which is particularly helpful in this setting. And this is the sapien valve implantation. The balloon is slowly inflated, expanding the stent, as you see here, which is the sapien valve is the same as implanted in the aortic position, but of course in the pulmonary it is mounted on the balloon in a reverse fashion. And that's the final angiogram. You see the perfectly restored pulmonary competence. Another example of a 25 dysfunctioning matrix conduit with both stenosis and regurgitation, as you see in this angiogram, and then the angiogram immediately after implantation of a 26 millimeter sapien valve. This is a perimount bioprosthesis. I show you an example of a Melody valve in valve. This is a 25 millimeter bioprosthesis where we felt be more reassuring to put a larger valve, and the sapien 26 was implanted. As you see, the balloon is inflating, expanding the stent of the sapien valve, and that's the immediate result with perfect competence of the valve. So we have two percutaneous tools to restore the competence in the pulmonary position. We have Melody and sapien. When to use them? In patients with conduits between 20 and 23 millimeters, both Melody and sapien can be used. For larger conduits, the sapien valve has to be used. And I would say in severely stenotic conduits, Melody is preferable as compared to sapien, and this is my opinion, because you see the Melody valve is functioning well, even if the stent is not fully expanded, because this is a biological, there's a bovine jugular vein. And even if the expansion is not perfectly rounded, the native valve of this bovine jugular vein is functioning pretty well. I mean, in all situations, even in smaller expansion. As opposed to the sapien, which is a tissue engineered valve, and for proper functioning, it needs to be fully expanded. The stent needs to be fully expanded, achieving a rounded shape, as you see in this unfast view of the stent. So in severely stenotic conduit, particularly if you anticipate that we will not be able to achieve a full expansion, Melody is preferable to sapien. But we have to choose the proper device from case to case. Well, the issue of patient with surgery without conduit between the right ventricle and the PA. Is that pulmonary valve implantation percutaneous technique feasible? The answer is yes, but only in selected cases where we will be able to secure a stent anchorage in the RV outflow tract. Well, this is an example of a tetralogy with coronary anomalies where the surgeon put a conduit between the right ventricle and PA, leaving the native outflow tract here. And with time, there was a severe pulmonary regurgitation through the native outflow tract. So it's easy to put a Melody there because it's enough stenotic to secure the stent anchorage. That's an example of a native outflow tract stenting. That's another example of a native outflow tract after surgical repair with patch, transannular patch. You may have some stenosis there, so it may be possible to put a stent there. So what you're going to test this situation with the balloon inflation, and you may argue that here there is a very mild residual waste, so may be possible to put a stent there. This is what we did. This is another stent which is inflated with a bit of calcium here and nice little waste. enough to keep the stent in position and to allow us to go ahead and put a sapient valve, which is expanded here as usually very, very slowly in the middle of the previously implanted stent. Go, 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 go. Okay, full expansion of the stent. And this is the immediate result with a perfectly competent valve in this native RV outflow tract. So this is it. I think just a few words about the possible future in the larger outflow tracts. There is a pioneer experience with a device that is self-expandable, and the first in-man was done actually by Philip Bonhoeffer and myself in January 2009, so many years ago actually. Then the project, for many reasons, stopped, and now is again on the table. And you see the immediate result in this particular case. We were obviously very happy about this success long time ago, or more or less 4 years ago, but the future is going to be a larger stent, probably self-expandable technique to be implanted in larger native outflow tract. Thank you very much for your attention.
Thank you, Professor Carminati. Congratulations for your work.
Thanks.
Please, if you want comments or questions. Dacă nu, îl invit pe doctorul.
Yes.
Thank you for the beautiful presentation. We all know that you are one of the most biggest, let's say you have the biggest experience in Europe. Can you, as you mentioned, 60%, more than 60% of these cases are with tetralogy of Fallot or pulmonary atresia with VSD. So one of the main problems for the surgeons are the reoperations for this type of patients, because as you mentioned, the right ventricle is right under the sternum, so the risk of bleeding is very important. So this type of procedure is important, but we have a lot of patients with transannular patch. So do you think the transannular patch is a limitation, or there is some possibility for tetralogy of Fallot?
Well, it's a limitation indeed, because if we have RV outflow tract which is too much dilated, is too large for put a stent in, we have to deal with other devices, larger ones. I mentioned to you the pioneer experience of self-expandable stent. That is probably the way to go.
So it's not the transannular patch itself is not a limitation. So a lot of people are saying that you need to have a.
Well, it is a limitation so far, because we don't have devices that are suitable for all kind of anatomy.
Okay. Yeah. Okay. Thank you very much.
Mulțumim, Horatiu. Thank you, Professor.